Everybody, I am Peter Schwartz. I'm the director of the IU Center for Bioethics, and it's my great pleasure today to introduce Dr. Meg Gaffney as our speaker in the IU Bioethics Grand Rounds series. I'm going to call her Meg. We should call each other, but I'm sorry, but Dr. Gaffney was a founding member of the Center for Bioethics a few years ago, and has been a cornerstone of the center ever since. She's an associate professor of medicine emeritus at the IU School of Medicine, if I have that right. She continues to be extremely active at the center after her retirement a few years ago. And again, I've had the pleasure of working with Meg for almost 20 years. Dr. Gaffney practiced dermatology at Eskenazi and continues to teach dermatology and ethics to medical students. She ran the Eskenazi Ethics Committee for many years, served on other important committees there, both there and at the Fairbanks Center for Medical Ethics. Of her many important roles, let me highlight one of them, which was really her role as a teacher. She was the director of the Moral Reasoning and Ethical Judgment Competency, as well as being the director of the Introduction to Clinical Medicine course for first year, and I think for some time for second year students as well. She ran an incredibly popular ethics elective for fourth year students for many years, created and ran that course. And as I tell everybody, because it intimidates me and impresses me, she won so many teaching awards, I can't count them. I actually tried to count them and I ran out of fingers, and that was it. So last thing I say about Dr. Gaffney is Dr. Gaffney is a teacher. That is really one of her wonderful roles. And we've all learned a lot from her about medical ethics and the practice of medicine. And I learned personally in those areas from her, as well as in the area of being a leader and a mentor to a certain degree. Again, always from her. I think we will all learn today from her lecture on conscience and ethics when principles are not enough. Thanks.
Thank you. Thank you all, but you should always hold the applause till the end. You may wish to withdraw. Thank you, Dr. Schwartz, for that very kind introduction. Good afternoon, and thank you for the invitation to share some ideas about conscience and ethics. Most of you know me, and Peter already sort of gave away part of the opening here. And I did have the privilege of practicing medicine, teaching students and residents, and serving as an ethics consultant in our hospitals for nearly 30 years. And it would be difficult for me to choose which of those roles actually held the most meaning. And of course, they are intimately connected. Teaching, I think, was the greatest gift. Caring for suffering persons was the greatest service. And wrestling with the moral questions related to our human condition was often the greatest challenge. Although it is impossible to separate these three, today's talk focuses primarily on ethics consultation, the practice of ethics consultation. And I want us to consider, just going forward, that perhaps principles and theories are important and necessary, but maybe not sufficient to fully address the messiest moral dilemmas that we encounter. Conscience-sensitive ethics and language augment. This is my proposal. Conscience-sensitive ethics and language augment ethical principles and theories approaches specifically by addressing moral emotions and moral attachments, two important aspects of any human encounter, but these are generally ignored by traditional bioethics and traditional approaches to ethics. So as you know, for many decades, bioethics has relied heavily on the use of four major ethical principles, many derived principles, and/or ethical theories to address and resolve ethical dilemmas. But what happens when theories, or maybe two or more principles, conflict or contradict, or they are just simply inadequate to address the important question of care or policy or relationship that's being presented? We're going to consider a couple examples in a minute. But what if, instead of asking, what am I to do in this situation, instead we ask, what am I to do? Thereby putting ourselves squarely in the middle of the moral dilemma. First, I'm going to share a case with you that we used with our first year medical students. As many of you know, in the Intro to Clinical Medicine course, we had my husband, Matt Galvin, to whom I owe most of this presentation and this wonderful work together. We taught together for 15 years. We had small groups, and so we would present this case that I'm going to show you in a minute. So this is a 26-year-old man with Crohn's disease, and he presents to the ED with toxic megacolon and a lower GI bleed. The hemoglobin is 6.4 and going down. His white, this is bad. The white cell count is 16.7. He appears oriented and competent, but despite resuscitative procedures, I just can't see this very well. He continues to bleed. Emergent total colectomy, so they want to take out his colon in order to save his life and stop the bleeding. Is scheduled. He agrees to the surgery, but he states because he is a Jehovah's Witness, under no circumstances will he consent to a transfusion. His wife and his family, basically his parents, are there with him, and they support his decision. The anesthesiologist is very torn, but she states that she will not transfuse him during surgery against his will, even if not doing so would result in his death. The senior surgeon, though, states that he has an obligation to do everything he can for the patient, and that it would be wrong to stand by and let a patient die under his care unnecessarily. The surgeon says he will not operate under these conditions. The patient will likely die without both the surgery and the transfusions. So we presented this case to our students, and we asked them to describe the moral dilemma or dilemmas that they could discern in this case, and then suggest a resolution and defend it, kind of explain how they got there and what they really think is going to happen. So we'll come back to the case toward the end here, and I'll tell you what the students said. The second case that I think presents a slightly different situation. So this is physician-assisted death, which we used to refer to as physician-assisted suicide. I think this is the current term now, assisted in death. Okay, so this is actually based on a case that did go to the US Supreme Court in the late 1990s. A 68-year-old woman has advanced metastatic breast cancer. She was diagnosed about 5 years previously, has received aggressive care, including surgery and chemotherapy, which actually produced a fairly good remission for a while, but now the cancer is returned and is progressing relentlessly. Her oncologist she's known for many years now, and he is deeply connected to her and committed to her care, but he is reluctantly concluding now that he's pretty much run out of non-palliative options. So he's not abandoning her, but he's saying, I just don't know that we have a lot more to do therapeutically. The patient understands and accepts, she's very sad, but she accepts that her death is approaching. Currently, she's homebound and actually now bedbound. She's not really able to eat anymore, and she is also suffering excruciating pain due to bony metastases. She has been enjoying pretty much the main joy of her life now are these visits from her daughter and her 2 young grandchildren. But recently the pain has become so severe that she's struggled to maintain her composure during their visits. And she's really worried. She does not want to frighten the little ones. And so she finally, very reluctantly, but she says to her daughter, please don't come anymore. I can't bear this anymore. During her doctor's next visit, she further requests information about medicine to help her end her life sooner, rather than continuing to suffer this agonizingly slow death. Her doctor understands and cares about her, but she's pretty conflicted. Okay, so that's the second case. Now, generally, we approach bioethics. I just have to say that this screen is very annoying. I'm not using it now, but
Whoops.
oh, thank you.
Are you using the microphone?
Yeah, I was. Thank you. Yeah, perfect. Thank you. Now I can actually see the 6 people in the room. Anyway, so the traditional approaches, which we're going to not spend too much time on. I hope you will realize I actually do know a little bit more about them than I'm going to share with you, but I'm assuming that everybody in the room and anybody who might be listening online is already pretty familiar with the four principles: autonomy, beneficence, non-maleficence, and justice. Major moral theories of consequentialism, also known as teleology, deontology, and virtue ethics. And there is an integrated approach by philosopher Rushworth Kidder. I don't know if anybody here is familiar, but I'll share that with you. It's I think, very helpful and applicable not just to healthcare ethics. And then there's this sort of the best fit. In general, it seems to me that moral people kind of use, we sort of move between calling on principles, calling on theories, to figure out what the best fit is for the moral problem in front of us. So many of you will recognize this schema. This is which we, at least us older people, have lovingly referred to as the Georgetown mantra, because it was, I think, mostly explicated by philosophers and theologians at Georgetown. So this is a very quick way of kind of trying to kind of get the principles at least out there for discussion. So in the upper left, the medical indications, which is basically what the healthcare team brings to the table. So the diagnosis, the prognosis, the therapeutic options, this is what you have, this is what I think we can do, and this is what we really think the outcomes are going to be. Balancing that is the patient preference, the patient, we say autonomy, auto is self, onomy is rule. I get to decide what happens to me. And as a general proposition, at least in the United States, if a person has decisional capacity, we say that they have competence as a legal definition, but decisional capacity, then the patient can actually accept or reject pretty much any treatment, including life-sustaining treatment, assuming that they meet the conditions of informed consent and decisional capacity. Sometimes, obviously, may not be able to meet all those conditions, and we'll talk about that just briefly in a minute. And we go to what were referred to as sort of the below the line considerations: quality of life, burdens. Quality of life, which is a phrase that really makes me nervous. It's like has a really terrible history in the not so distant past. Who decides what's quality for whose life? And so theoretically, obviously, it should be the patient saying, I can live with this, I cannot live with that. Another way of trying to kind of frame it is to look at the burdens and the benefits of both the condition and the proposed treatment on the patient, for the patient. And then finally, the last box there is consideration of other factors. It could be a resource allocation, it could be other patients, could be the providers. In general, we put this together under the concept of justice, what is due or owed. Not only the patient here, but also other moral stakeholders, other components of the healthcare situation, whatever it is. We don't often spend a lot of time with justice, unfortunately, but all right, now this is what I have. Okay, moral theories. And Tom, just don't jump out of your seat here. Again, this is a brief description here, but we have, there are three that at least that I'm just gonna highlight today that seem to be pretty useful in healthcare ethics. Consequentialism, which sort of is crassly referred to as the ends justify the means, or the greatest good for the greatest number. And this is an end-based reasoning in which the moral goodness or rightness of an act depends almost entirely on the outcomes. It's also sometimes referred to as utilitarianism or teleology, teleo meaning ends. So that's consequentialism, and that's a very practical way of ordering our thoughts. You know, if I do this, what's the outcome going to be? If I spend money on a fancy car, can I still send my kid to college, et cetera? Deontology is really pretty different, and basically, deon is Greek for duty, and it says actually that the moral rightness or goodness of an action is really based on a highest principle or rule, the one thing that you don't want to violate. And in the ends, may in fact be regrettable, but you may still have to follow this highest principle or rule. And you can see where a deontologist talking to a consequentialist might have a little bit of conflict here. And then finally, virtue is another one. And Dr. Ed Pellegrino, who was at Georgetown also, was a very big proponent of virtue theory, in which, one of the central questions is, what would a good person do in this situation? A good parent, a good teacher, a good nurse, a good doctor, et cetera. It seems also to be related to the golden rule to treat others as we would like to be treated. So again, this is a very, very superficial overview, but you sort of get the flavor that there are different ways of approaching major moral issues. Okay, so Rushworth Kidder, just a moment about him. He's a fascinating guy. He's a philosopher, and he also for years and years was a columnist for the Christian Science Monitor, which he wrote human interest stories. And he became, and then he started collecting them and started analyzing them. And he was just struck by, oh gosh, the complexity and the poignancy and sometimes the tragic nature of decisions that ordinary people had to make pretty much every day. I mean, they're just, unusual. And so he wrote this book called How Good People Make Tough Choices, published in 1995. I think it's a very practical book, and it looks at everything from libraries to police work to teaching, a little bit of healthcare, and just a very nice, I think, exploration and easy to read. He also stresses that in his mind, a dilemma is a conflict between two rights, not a right versus wrong. This is a two right, not my right to healthcare, but under ordinary moral circumstances, in fact, I should do this, but I also should do this, and I can't do both. And as during his analysis, came up with these 4 dilemma paradigms in which he said the conflict was between justice and mercy, truth versus loyalty, individual versus community, and short-term versus long-term. And it's not as if justice is right and mercy is wrong, or short-term is right and long-term is wrong. It's that under ordinary moral circumstances, we would be morally bound to be both just and merciful, to be concerned with truth and loyalty, individual and community, and short-term versus long-term. But under certain moments of moral choosing, you can't do both. You have to choose. And it also, same thing with the principles, it seems, that even if one becomes ascendant, doesn't mean that the other goes away. We still have some duty to respect whatever is the other half of this. But one may in fact become the ascendant, either principle or. So I think I do recommend the book. It's like I said, it's a nice read, a pretty easy read. So, and as I said already, as a practical matter, conscientious people kind of access any of these, sometimes all of these, depending on what the problem is or what their issue is. Okay, so, but we know, as I've already said, my personal belief that these approaches all have some certain inherent limitations. So first, when we talk about ethical principles, they represent prima facie duties. That is, under ordinary moral circumstances, we are bound to follow them. We are bound to respect autonomy, to be beneficent, non-maleficent, and just. Sometimes, in fact, we cannot do that because they conflict with each other, or we can't, the conditions for meeting them are not there. So think, for example, of a person who is incapable or unwilling to make a decision for himself or herself. They can't choose, or, one that was, as on the healthcare side of things, I think medical uncertainty, very difficult to live with. I just don't know if this second round or 10th round of chemotherapy will benefit you or just prolong your excruciating agony. It's horrible to have to say, I don't know. Patients don't like it, doctors don't like it, healthcare teams don't like it, but sometimes that's where we find ourselves. Sometimes preferring consequentialism may lead to unforeseen and unacceptable ends, right? Most of the time we can't really see. It's like, oops, I didn't see that one coming. We think we can protect against a lot of unforeseen stuff, but obviously in medicine things happen and we cannot. And also, as I mentioned before, consequentialist ends may in fact violate some breach of a highest principle, or at least come in conflict with it again. And virtue is interesting, of course. Virtuous physicians have different understandings of what a good practice is, right? How best to proceed. So take the example in the physician aid in dying. A consequentialist approach might say the end, that is her death, is going to be the same, right? And in fact, you might be able to limit suffering. So that'd be a good thing, right? It doesn't take account for consequences to other stakeholders, right? That's just one thing. The deontologist also might counter that killing or assisting in death is wrong, always. That's the highest principle. And also that deontological physician may in fact be unable to adequately address the autonomous person's request for an ease of this unmitigated suffering. So it seems the major moral question to me seems to be, how does a compassionate physician, healthcare team writ large, respond to a patient's unrelieved suffering? So language plays a role. I do, I was an English major. I do love language, and I do think language is so powerful, the way we frame things, the way what we put in, what we don't put in, informed consent, I think probably the hardest ethical duty we have. Medical language strives to be the language of science, objective, facts, just the facts, man. So-called value neutral, which never seemed to make any sense to me. We are not value neutral, truly, but certainly when I was in school, that was what was stressed. The relentless pursuit of objective observation, driven by its own values, there we go, may nonetheless silence a larger language of values. Moral language is the language of values and virtues, and at some point, moral language becomes personal. I choose to do this because of the values I hold and the image I have of myself as a good person, as a good doctor. Relying only on principles or theories to resolve an ethical dilemma, a conflict between two rights, may lead to an unsatisfactory resolution for some or all the parties involved. So in the case of the Jehovah's Witness patient, most medical students and many of our colleagues frame the dilemma as a conflict between patient autonomy and physician beneficence. Now, I realize that many experienced people in this room and also online, maybe, don't limit their ethical consideration quite so stringently. But this is actually how the medical students first responded. And for the purposes of discussion, I'm just starting from here. And in our discussions, the case discussion was pretty short. The medical students said, what's the big deal here? The patient gets to decide. Autonomy supersedes beneficence. This is an easy case. And when in doubt, just go to the court. Ask the judge to decide. We did get that many times. Well, so some of us who have lived with this very similar scenario would identify some unresolved concerns here. And similarly, the physician aid in dying situation is often framed as a conflict between the autonomous patient's request and a beneficent, non-maleficent physician's response. Or what does justice look like in this particular situation? But as we said already, each has certain problematic limitations. We're going to come back to these one more time at the end. So how do we acknowledge the fuller context of a patient's life and the lives of the other moral stakeholders, including the healthcare team, the providers? And this is where I think conscience theory and language can really be helpful. Through a consideration of connectedness, moral emotions and values, conscience language and theory may act as a bridge linking ethical theory and principles with the profession and practice of medicine. Very brief history of conscience. A theory of conscience formation and functioning was initially developed to account for empirical findings from a study on the moral developmental psychology of children and adolescents. And the study was begun in the early 1980s. Dr. Barbara Stillwell and Dr. Matt Galvin were the first two researchers. The studies began with children in advantage. So children who lived in a safe place, who had fairly stable families. They went to school, they had food, they were safe. And so that was what the empirical studies, that's where they began and developed this theory. But of course, not all children live in advantage and security. And in the meantime, Matt, my husband, was working primarily with children who were suffering pretty serious adverse life experiences, where they were either victims of or were witness to violence, broken homes, parents who were unavailable because of illness, or maybe they were in jail, or they were just unable to cope. The children didn't have food, they were homeless, et cetera. You can make the list yourself. So those were the children in adversity. And then the team was contacted by a psychiatrist who was Armenian, and he wanted to look at the effects of catastrophe on the development of conscience in children. And he was looking at the effects of a 1988 earthquake in Armenia, a devastating earthquake. And so we have 3 sets of interviews and statistical analysis of these children. And of course, we're looking to see what effect can they have. I will say that the initial, here's the overall initial theory for conscience. So there are 3 parts to it: the stages, domains, and intrinsic values. We're not going to really speak much about staging. Staging really, assuming, again, starting with children in advantage situations, safe situations, stages of conscience development pretty much developed related to age. I mean, age and life experience. Of course, if you throw in terrible life experience or a major catastrophe, then you would think that some might get disrupted in there. We have 5 domains of conscience, which we're going to go through, and then the intrinsic values related, one each to the domain. All right, so conceptualization of conscience, also known as the moral imagination of conscience domain. So this is kind of the anchor domain. And the way we did, now I'll switch to my teaching real briefly. So because we did this with our medical students, we had 5 tasks that we did over 5 different sessions. And for this one, we asked the students to draw a picture, to imagine, tell us have you heard of the word conscience? What is it? How does it work? How does it work for you and in you? And then to draw a picture of it. And it was, and this is what we were also doing with children in advantage and adversity, and the children who had been in the earthquake. And so a person provides a basic definition of what governs their moral life, a consciousness of how they are composed as a moral being personally. Conceptualization anchors the developmental features of the other 4 domains, and any of the 4 may be salient in current conscience functioning and formation. And we refer to the variety, this wonderful variety that we would have in every group that we've ever had, and in this room, I'm sure, as a contour of conscience. And just for the record, all of these are good. There's no ranking here. They're all important. And all of us as persons of conscience have some representation of each of these domains. There may be more. These are the ones that have been identified so far. But in some of us, one or the other will sort of come to the fore, will be more important, more salient in the way we approach our moral lives. But it's all good, just so you know. Sometimes the students would say, well, which one is it? Which is the best? I was like, no, they're all good. So then moving on to moral emotional responsiveness domain. So this is an interesting one, and one of the ones that I think is especially important that's overlooked in when we only use principles and theories. That this is the domain that ties morality to physiology. So think about if you've, when I've done some, I'll use the I statement. When I've done something that I think may not be correct or the best, sometimes I have GI distress, or I don't sleep, or when I'm brushing my teeth at night and I look in the mirror, I go, "Ooh, this is not good." So some people get headaches, some people muscle tension, but this is a way that our bodies are telling us in a way that maybe something is not right. Transitions occur in the ways that emotions are perceived as regulating moral behavior in response to an am good, feel good sort of personal moral emotional barometer. That makes sense. Sort of, we kind of want it to stay sort of in the middle range there. Deviations from the am good, feel good point create uncomfortable feelings that motivate either pro-social behavior, I gotta do better, or inhibit antisocial behavior or harmful behavior. They also can motivate processes of reparation and healing after wrongdoing or making mistakes. The intrinsic value here is balance or harmony. We want for ourselves and for our students, our patients, our loved ones, a full range of moral emotions, right? But we kind of like to live sort of in a more balanced way. And just as an aside with the medical students, the first thing we would say was name a moral emotion. This was very hard for them to do. So if I just ask the group, name a moral emotion.
Guilt.
Always the first, almost always the first one, yeah. And sometimes the students couldn't go on. It's like, anyway, all right. So we're gonna go on now. Moral valuation. In the moral valuation domain, transitions occur in the process of defining, prioritizing, and justifying moral rules on behalf of values. So I hold this value, and now this is what I'm gonna do. And the rules are categorized within a triune relational context referred to as a valuational triangle. This is, I think, a very interesting triangle. So there are rules that sustain respect for authority, rules that sustain self-respect, self-development, and future responsibility. And finally, rules that sustain respect for and promote responsibility among equals, so peers. So authority, self, and peers, right? Moral reasoning and psychological defenses both operate in this domain of moral valuation. The intrinsic value here is worth or worthiness. Sort of like, how do you value a value? But we came up with this worth or worthiness. The moralization of attachment domain holds processes and activities of the other domains within the bonds of human relationship. Excuse me, internalization of another's moral presence in one's own conscience concept. I recognize Sam's moral concept within my own. Bless you. One's own moral emotional experience of others via empathic and sympathetic arousal, creation of rules that value others' needs, establishment of relationship hierarchies and fairness among equals. And in the domain of moral volition, it helps transform agency into advocacy on behalf of another. So we have autonomy, agency, advocacy. Empathy, which we talk about all the time. Empathy finds its home in moral attachment, but it does its work in moral emotional responsiveness. The intrinsic value for attachment is connectedness. So in other words, I work on my attachments in order to strengthen my connectedness. And finally, moral volition. In this domain, this is pretty easy to relate to the principles, right? Autonomy and will are coordinated with the felt obligation to restrain or to take action. Autonomy, the recognition of the self as an independent, and will, the way an independent person intentionally chooses and directs his or her behavior. Two processes are at play here. Self-evaluation in the light of external and internal standards. Okay, what's going on inside. And conscious choosing to engage in pro-social and to refrain from antisocial behavior. The intrinsic value here would be freedom. I am free to choose and free to act. Research identified various life experiences accelerated, impeded, or even derailed a developing conscience. As you can imagine, time does not permit a fuller explanation or the citation of many peer-reviewed studies, but they're all on the Conscience website, which I have helpfully provided at the end of the talk. Okay, so back to the Jehovah's Witness case. I already said the students made short work of this. They said, what's the big deal? Just go to a judge, or, just let that autonomy decide. So we asked them to circle back, and we said, okay, apply conscience language to the case while they considered three of the major moral participants: the patient, the anesthesiologist, and the surgeon, all persons of conscience, and imagine the dilemma from each of their perspectives. So starting with the patient, obviously autonomous choosing, moral volition applies. He wants surgery, but not transfusion. I'm assuming that most everybody understands about the prohibition against blood transfusion. This would be considered a desecration for the most faithful of the Jehovah's Witnesses. With respect to moral attachment, it would be important to explore the patient's web of relations with his family. We know a little bit, they say his parents and his wife are supportive, but what about the rest of the family? With friends, with coworkers, what will this decision mean to his wife and his parents, other members of his religious community, and also on the physicians who are caring for him? The truth of his connectedness locates him within many communities, all of which will be affected by his choice. The values of the religious teachings are powerful and external motivators, but what of his personal sense of the worth of his own life? Perhaps the two are inextricably bound, but one does not know unless questions about the relationship between physical and spiritual survival values are actually explored. The patient could be asked, for instance, how would you respond in terms of moral emotions if you were transfused against your will? And finally, does the patient experience any moral emotions in response to putting his physicians in this moral dilemma? Pretty hard question to ask, but at least one we might contemplate. Now, going to the anesthesiologist, bound by professional values and the principle of beneficence, primarily, nevertheless believes the patient's choice takes precedence. An important question for her would be, how will you respond if the patient does die and your transfusion could have prevented his death? And how do you react to being put in this position of choice? And finally, the surgeon is maybe the most poignant. He's bound by the same oath as the anesthesiologist, but holds obviously a different understanding of medical and moral duty. I'm leaving aside the more survival things like malpractice and stuff like that. We're leaving that out here. Perhaps he is more tightly connected to medical principles in his community of medical peers. Maybe he values the patient's physical survival over the patient's religious beliefs and related right to refuse treatment. The surgeon believes that to allow a preventable death is not a choice for him. Perhaps the most poignant questions to put to this physician are, how will you be affected if you refuse to operate, thus ensuring beyond a reasonable doubt that the patient will die? Or how will you react if you operate and transfuse the patient who survives, but accuses you of desecrating him and condemning him to eternal damnation? And finally, how do these two physicians feel about each other? How do they reconcile this professional disagreement here? Moral valuation, our third big one. So connectedness, moral emotional responsiveness, and valuation involves the intrinsic value of the worth or worthiness of those three sets of values, right? The considerations of authority, self, and peer. Patient and providers seek and keep values and hold respect for self and others as persons of conscience. So exploring these three additional aspects of a seemingly easy scenario leads to a richer understanding of the humans involved and their struggles to respect themselves and others as persons of conscience. The outcome of the case, the answer, if you will, It may be the same, autonomy over beneficence, but the deeper understandings gained through this exploration of conscience may have profound consequences on the moral survivors of such a difficult human intersection. So let's do one more minute with we're just about done. Physician aid in dying. So again, it is noted, it seems incompletely framed by many, as many do, as a conflict between autonomy, a choice to die, which really may be a choice to escape suffering, and beneficence. And what role does justice play? What would it look like? But dying persons, as we know, no matter how independently they have lived, rarely die entirely alone. Even the unhoused person who's lived under the bridge. And conscientious physicians rarely abandon their suffering patients to professional mandates or rules. So back to the question, how does a compassionate physician respond to a patient's unrelievable suffering? I don't know, but I think you have to consideration of the values of loyalty, connectedness, harmony, and love are all morally relevant to both the patient and the provider, particularly in a case where this physician actually knows and has cared for this patient. So in closing, I would say, I started with saying that principles and theories are limited. And I would say, like the principles and theories, conscience theory will not easily resolve the thorniest dilemmas, but it may help enlarge and enrich the conversation and the debate by emphasizing respect for self and others as moral stakeholders, addressing the moral emotional suffering of guilt, grief, and reparation, and by acknowledging the ties that bind us all in our moral communities. Thank you.
We have, I don't know if people can hear you, I would say into your microphone, if you could hear the one white mic, that people can put questions in the chat or the question and answer boxes, and we'll monitor those and read them out to you. But we also have people in the audience, I don't know if anybody has questions in the in-person group first, to give the typists online time.
Oh, I can.
Oh, maybe we should do that.
Oh, I don't, yeah, sure. If you take it away, Kayla. Take it away. Oh, okay. There you go.
There you go.
Hello.
There you are. Don't be
So who is that person?
Anybody questions? Awesome.
Okay.
Just to kill time while others.
Yeah.
Oh, there's one coming up. Let me ask a question. So I was gonna say, for the wonderful complexity of the cases and the exploration of the conscience factors, often we don't have much time, right?
Yeah.
The patient in the Jehovah's Witness case,
Right.
there's not much time. I guess in the physician aid in dying and medical aid in dying,
Yeah.
I think they call it now.
Oh, okay.
There's more time, but is that a consideration in terms of thinking about these concepts and applying them?
Yeah, of course. So I think I'll repeat the question just in case, right? So the question is about time. Isn't that always our question? That's always, we don't have time. I guess my sort of facetious response, which is not doing you justice, Peter, is that this is, we do have time. We choose how to spend our time. It's true. If a patient is actively dying, obviously we don't have a lot of time with a person. But I think for a lot of what I would hope is that maybe not right in the moment, that the tragic moment right at the end, that we would have had some time to do some better in our history taking, in our being with our patient. I'll just say just a quick personal thing. My sister just had a medical and surgical emergency last month, and there were hours that went by and nobody touched her. Not a nurse, not a doctor, not a technician. Nobody touched her physically. They did scans and they told her what her CAT scan showed, and but it was really interesting to me and somewhat appalling. But anyway, but yeah, sure. I think you do the best you can at the moment. And of course, for instance, for the Jehovah's Witness case, it's fortunate if you have family there. Of course, the worst scenario is what one we often had, and many of our ethics consultations, when the patient was in fact a stranger in an emergent or urgent situation, and very difficult. Obviously, it's not perfect, and you do the best you can.
You have questions now. Okay, Kayla will ask you questions from
Okay.
online, and you can repeat them.
Okay.
So the first question is from, I think, Jerry Odell. So
Hi,
conscience,
Jerry.
so conscience is often used in the context of refusal to participate in care or shared community policies or rules. How do you help people avoid this angle while thinking about the role of conscience in ethical deliberation?
Oh, Jerry, why don't you ask? So the question, Jerry Odell, who's a member of the Conscience Project, I'd just like to say, and is a wonderful librarian, faculty member, started at the Center for Bioethics and then moved to the IUI library, IUPY. Trying to get used to that. And yes, and conscience, and I also have to say, so the question is, conscience is often used as a way of refusing to do something. My conscience forbids me to participate in a certain kind of care, and you can, fill that in, the usual suspects. One thing I do, at least in teaching for residents and students, is I would say, I ask them to write down a situation in which they thought that they had either an opportunity to or actually had done a conscientious refusal or positive, what's the word I'm looking for? Affirmation. And a lot of the situations were, they were not reproductive health care, a lot in death and dying. The question about, this is a dramatic one about asking a person actually asking for aid in dying. But there's lots in between, from terminal diagnosis to actually actively dying. Conscience has been used as a bludgeon sometimes and a weapon. I think it depends on the circumstance, I guess I would say. But one thing for me is to try not to get too emotional. You might imagine that I'm in the MER, in the moral attachment category, pretty much. To try to again, if I believe that the person who's with whom I'm conversing is a person of conscience, then I owe certain respect and careful listening to that person, to invite them to explain better, their reasoning, where they're coming from, to try to hold up the other side. If this is a conscience refusal, what are the consequences? What is, what is, if you refuse to do this, what happens next? So to look at it from a consequentialist perspective. For policy, I think you got to have people representing 2 sides, 3 sides, 4 sides. It's not just a dilemma. It might be a trilemma. There may be other options. That's the best I can do right now. Yeah.
And then there's another question by Jane Schultz, from Jane Schultz. Says, how does the cultural moment possibly affect issues like autonomy? An example, in the 19th century or even well into the 20th century, patients' autonomy would not have been considered very important.
Right.
But in 2024, it's very important. What I take from this is that practice is far more difficult for medical stakeholders today than it was in the past.
Okay, so the question from Professor Jane Schultz, who says autonomy, it's basically autonomy is kind of a 20th century phenomena, really actually late 20th century, 1960s, 70s on. Autonomy, yeah, I would like to say that physicians had sort of a long run from about Hippocrates to about 1960. You know, physicians made the decisions, basically told you what you had, told you what was going to happen, and the patient said, okay, you know, basically. And then things really started to change. And I think that the move in healthcare to recognize a person's right to know what's happening, to make some choices within certain guidelines, if you will, with certain help, really also reflected civil rights, women's rights, other kind of rights language that really became ascendant in the 60s and 70s and 80s, obviously. As to making it more of a challenge, if I'm understanding Professor Schultz's question right, is it, are you trying to say that it's harder for a doctor to actually have to explain to his or her patient what's going on and to actually abide by their decision? Yeah, sometimes. And there's the time thing comes in, and we have patients. I had many students who would say, well, this patient just can't understand, just, you know, doesn't. And I go, it's our job to help them understand. And that's the point, is that, and you do this with risk all the time, you work with risk. And so I do think in this case, time is too bad. Take the time, you know, work on it. People, I do believe that most people understand something true about their body, and if we can use the right language, that is our moral obligation. I do think it's hard sometimes, tricky. I don't know if that, yes, Heather.
So I was wondering if you did any work looking at the role that religion plays in the development, just because, you know, like Jehovah's Witness example, he considers it a desecration of his body. So, like, how do we work that into conscious, and how do doctors take that into consideration when they have a conflicting, maybe religious belief?
Yeah, great question. So the question has to do with the role of religion in conscience, or religion in healthcare, for either asking for or rejecting therapy. The first thing I'll say is that a couple of things. One is that both as in the research, but also in our teaching and certainly in our practice, we never define conscience. My definition is different from yours. It's like I said, you know, it's pretty much all good what people come up with. Some people, and we've done, I would say, we've been very, very privileged, have asked several hundred people, tell me about your conscience. And some people, the first several, you know, parts of it are what the church tells me. We had one medical student who said he had just come out, he had gone straight from Catholic high school to Notre Dame, and he was a first-year med student. He said, my conscience is whatever the church tells me. It's like, I was a little worried about him. And we had a student at the other end of the table who just got bright red in the face, said, oh my God, I haven't been to church since I was 12. Does that mean I don't have a conscience? Of course, it doesn't mean that. So yes, some people will, and again, when you think about the triangle, the authority triangle, church or religious teaching obviously can be very potent authority, especially early on as we're developing. Most of us sort of incorporate and make it more personal. That's the role. For the second part of the, I hope that yeah. So for the second part of it is that the role of religion in healthcare, and Peter, you could speak to this too. I do think two things. One is that if a person has a religious, this is just my observation over 30 years. If a person says, oh, I can't do that because my religion forbids it, or I have a religious, boy, we just tend to back away. Like, don't even ask questions. Like, okay, if I said, no, I don't want to because I don't feel like it, or then we might be pushing a little bit harder. And I think it's wrong. I think even in the case with the Jehovah's Witness, sensitively, compassionately, but ask the question, help me understand what this means to you. I think that's not only okay, it's really necessary. For respecting religious difference, sometimes for a physician, if a physician had very strongly held religious beliefs, then yes, I can imagine that there would be it would be harder. And of course, you know, for certain things like a Catholic physician in reproductive health care, probably not a great match. But, you know, there are wonderful Catholic physicians in reproductive health care. But I just think that there's a certain kind of stress that would be perhaps added to that. The bottom line is that, again, this is my personal feeling, is that medicine is asymmetric. Not only physician and patient, no matter how hard I tried, I couldn't quite make us completely. I went to school too many years, you know, I just have too different of an experience. All healthcare providers, I think. Of course, we're the ones standing up and the patient's the one laying down. So right there's an asymmetry. So I don't know if that kind of helps, but yeah, it's a complicated. And if you're lucky enough to get to know the person, it goes better, obviously.
So we're kind of out of time. We have one last question
Okay.
online. Do you want to try to take
Sure,
a shot at it?
Sure.
30 seconds. No time, remember?
No time, right?
Somebody said, what evidence or data do you have, if any, on development of the characteristics of conscience over time from childhood to adulthood?
Yes. Okay. So
You only have 20 seconds.
right. No. So what I would say is go to the Conscience website, and the peer-reviewed articles starting from the middle 1980s are there. Yes. So the data was subjected to statistical analysis, and so and the papers. Each domain has its own paper that describes how the domain was sort of not elicited, but viewed and described.
The age of people, like as people get older, does conscience change?
Oh, I'm sorry.
Yeah.
Oh, yeah. Well, we think so. Yes. In fact, that's one of the questions that we would ask students. You know, how is this different from how it was before? Do you feel like your conscience is still evolving? And most people, I think, would say yes, but I don't think we'd have any empirical data on that.
Well, thank you so much, Meg.
Thank you.
Everybody online for being here and everybody.
Yes. Thank you, online people. That's it.